On behalf of the Centers of Medicare and Medicaid Services, the Administration for Community Living, and the Indian Health Service, I would like to welcome everyone to the Long-Term Services and Supports webinar series. My name is Julie Cahoon and I work for Kaufman and Associates. I will be the moderator for today's webinar. Before we begin, I'd like to highlight the main features of your webinar interface. First is the main window where you see the PowerPoint slides. To the bottom right of the window is the Q&A pod. You can enter a question for our presenters at any time in the Q&A pod. A Q&A session will take place after the presentation. If you need technical assistance during the webinar, please enter your tech support question in the Q&A pod. Our tech support staff will be monitoring these questions throughout the webinar and will work to answer your tech support questions right away. You'll receive an answer in the Q&A pod. Finally, please be aware that today's webinar is being recorded and that the recording will be made available online in the near future on cms.gov. Please note this webinar series is supported by the Centers of Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenters and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicare and Medicaid Services. With those announcements made, I'd like to welcome everyone to today's webinar. Today's webinar is titled Changing Tribal Demographics in Post-Acute Care. Today's webinar is supported by Unite, the Uniting Nursing Homes and Tribal Excellence Group. Today will be a panel discussion about post-acute care in a rehabilitation setting and a nursing home care setting. Our panelists today include Ina Hurley, the Human Resource Director for Morningstar Care Center, Susan Poirier, the consultant for Native American nursing homes through the Native American Health Management, Joseph Ray, the Executive Director for the Native American Independent Living, Tammy Reed, the Administrator for the Morningstar Care Center, and Dana Schlegel, the Clinical Liaison for Mountain Valley Regional Rehabilitation Hospital. I will now turn it over to Tammy to provide an introduction to today's topic.
Thank you, Julie. I want to welcome all of you to today's webinar. We really appreciate you joining us today as we have our panel discussion regarding tribal demographics in post-acute care. Our intention today is to provide a well-rounded discussion for you regarding the post-acute care in Indian country with both positive and negative aspects that we see on a daily basis. And we really, truly welcome your questions. Today's objectives are understanding the similarities and differences between rehabilitation hospitals and skilled nursing facilities as it relates to the length of stay and funding for many people, to recognize the changing typical admission in terms of age and diagnosis, as we are seeing a lot of changes in this area, and becoming aware of similar care needs and challenges in both types of post-acute care facilities as well as long-term care services. I would like to briefly allow our panel to introduce themselves, and so I will start with Susan.
Well, good morning from South Dakota. It is noon here and it snowed this morning. My name is Susan Poirier. I'm an enrolled member of the Oglala Sioux tribe. I was born and raised here all my life, and I live on our ranch. I currently work for Native American Health Management. I'm a consultant helping other Native tribes get their nursing homes up and running and helping them sustain their own nursing homes on their own land. Thank you.
Thank you. Dana?
Hi, my name is Dana Schlegel, and I'm a registered nurse, and I practice in the area of acute rehabilitation. I have been in this practice for the last 30 years, and specifically I've been in northern Arizona for the most of my practice. So I've been able to work out on the reservation and provide Native American care in Flagstaff, Arizona. Thank you.
Ina?
Good morning. My name is Ina Hurley. I am an Asian Shoshone tribal member. I reside here in the Wind River reservation in Wyoming, and I've been a long life resident here. So, and I am in the Human Resource Department with Morningstar Care Center. Also, I'm a staff development coordinator and an Eat an Alternative educator. So, a lot of good things happening. Thank you.
Joseph?
Guatsi Hupa. Guai. Joseph Ray, Laguna Pueblo, Guayca. And my clans are Eagle and Corn. So I wanted to say good morning to all my relatives out there in throughout the land. I am executive director of Native American Independent Living, founding member, and also advocate for our tribal elders here at Laguna Pueblo. I'm serving my second term with the local board of directors of the Laguna Rainbow Corporation. We oversee management of our community senior center, Title VI and Title III services, and also a 56-bed nursing home, skilled care nursing home. Thank you.
And my name is Tammy Reed. I'm a lifelong resident of the Wind River Reservation here. I am the administrator at Morningstar Care Center, and we are owned by the Eastern Shoshone Tribe. And so I welcome all of you today. I would like to tell you a little bit about Unite. Unite was the brainchild of a beautiful woman named Kay Branch, who's no longer with us, but her life, love, and passion was to help Alaska Native elders. And in her work, she believed that the rest of us through Indian country should get together and collaborate so that we had support and had strength and have that ability to promote tribal nursing homes as well as long-term care services and elder care throughout our Indian country and Alaska and Hawaii. And so we had our first meeting in the fall of 2015. I was very fortunate to be part of that groundwork. And the name that we chose at that time was called TREACH, which stood for Tribal Educational Nursing Home Collaborative. Over the past 4 years, we have progressively grown, and we are now known as Unite, which stands for Uniting Nursing Homes and Tribal Excellence. We are a collaborative group across the United States. We have members in the United States and Alaska with many different tribes. We work towards promoting tribal nursing homes, assisted living facilities, long-term care services, and we try to do this through education, training, best practices, culturally relevant education, and quality improvement initiatives. We have progressed to the point that we've become a nonprofit 501c3 corporation. We have a full board of directors, and we're very, very excited to see what the future holds for us as we're working very hard on this. We do always welcome new members, and we do appreciate any support that you give us for our Unite group in helping others to have facilities that currently perhaps their tribes don't have anything. So with that, I am going to turn it over to Dana.
Thank you so much. And I just really appreciate the fact that you invited me to speak. And what my purpose is really just to explain to you what acute rehabilitation is, how it fits into the post-acute care, the similarities and the differences of an acute rehabilitation center versus a skilled nursing facility. Acute rehabilitation is in the post-acute benefit package. It serves individuals that may have experienced life-altering disabilities. Some of the conditions that we see in our area are traumatic spinal cord injuries, traumatic brain injuries, strokes. We have trauma secondary to horse accidents, substance abuse, car accidents. And then we have a lot of chronic accumulated medical conditions that have caused a significant functional decline. Oftentimes we will see diabetes, end-stage renal disease, amputations. Their conditions, these medical conditions are such that require multidisciplinary team approaches in order to promote our recovery into obtaining the highest functional level ability. We participate, our individuals that come to acute rehabilitation will participate in 3 hours of therapy. Their medical care will be managed by a physician licensed in a specialty area called physical medicine and rehab. You may hear that also called PM&R or a physiatrist. So they're very specialized, board certified. Our facility will treat anybody within northern Arizona that meets any of this criteria. In Arizona, our company that I work for is called Ernest Healthcare, and we have 28 acute rehabilitations throughout the nation. But the service area I work in northern Arizona, we specialize in the care of rural health. Are the back door to the largest Native American tribe, the Navajo tribe, and we've served them for 13 years. And in Flagstaff, we opened up a facility specific to the Native American tribes. And in our facility in Flagstaff, we have 35% of our population is Native American. And the interesting part of that is when you look at national statistics for acute rehabilitation throughout the nation, Native Americans are only served 0.6, so not even 1% of the admissions throughout the nation are Native American. And in our facility in Flagstaff, we're at 35.5. So that's quite a privilege to be able to serve that population. We are similar to a skilled nursing facility. Skilled nursing facilities will oftentimes refer to themselves as rehabilitation facilities. It does confuse the community because they think it's the same thing. They do have, I'm not an expert in skilled nursing facilities, however, skilled nursing does have physical therapy available in their buildings. They generally have a gym. They will generally have a practitioner. They will have a physician and nurse practitioner that are seeing patients. I believe that in the post-acute area between skilled nursing and acute rehab that we serve the same interest. That is getting individuals treated at the right level, at the right time, for the right reasons. And I hold tight to that philosophy. Differences in an acute rehabilitation, we are reimbursed at a higher amount. So that affords us the ability to have more intensive staff ratios. In skilled nursing facilities, their ratios for registered nurses for an 8-hour shift might be you have one available. In our facility, we have one registered nurse for anywhere between 6 and 8 patients, and that's 24 hours a day. These nurses are also specialty trained in rehabilitation. Our physicians, our physical medicine and rehab doctors, see our patients at a minimum of 3 times a week. And then we have overlaid in top of that, we have internal medicine. So we have a well-rounded medical treatment team. We have physical therapy, occupational therapy, speech therapy. These are all specialty trained therapists that go on to get certifications in neurorehabilitation. They are treating patients 3 hours a day. And pulling that together, then the length of stay are significantly different in regards to a skilled nursing facility. Our average in the nation, the length of stay for an acute rehabilitation is approximately 14 days. Skilled nursing, I can't talk to what their length of stay, but they're greater than 21. So that's a really rapid recovery. And then also in acute rehabilitation, we have state-of-the-art equipment. We have state-of-the-art gymnasiums. Our facilities in both Mountain Valley Rehab in Prescott Valley and in Flagstaff, our gyms exceed 8,000 square feet, so they're very large. We have specialty ambulation equipment for people that have had spinal cord injuries, that have had weight-bearing restrictions, that may be cognitively not intact but need to bear weight through their legs. So that's really what I wanted to talk about in regards to what an acute rehabilitation looks like.
And so I think that from our standpoint in the long-term care, the history recently in long-term care services and support services has expanded quite a great deal. because there's a wider variety of choices for people nowadays, whether it's a skilled nursing care, home health, assisted living, adult daycare, and that's just to mention a few. A skilled nursing facility for most of us is regulated by CMS laws, and it does provide nursing services 24 hours a day. Now, there is a problem with some families that we see who think they can just bring their loved one here because they're having difficulty taking care of them at home, and they just come and say, you know, Grandma needs to live here with you. And that's not the case. You do need a doctor's referral in order to come to the nursing home. But we do provide nursing services that might include dispensing medications, meals, rehab services, such as physical, occupational, and speech therapy. A skilled nursing facility also provides specialized treatment, perhaps for stroke recovery, diabetes with dialysis needs, dementia needs, wound care, and other acute medical conditions. While we are not a rehab unit at a long-term care services, we do provide restorative and skilled therapy on a daily basis or whatever time limit the doctor is wanting based on that doctor care plan that they have. I think that one of the differences that we are seeing in this long-term care process is we are seeing a difference in population as more and more people at a younger age are coming to the nursing home and needing some specialized care, whether it's through chronic disease or other situations, which we will go into further. Julie, did you want to have a second here?
So at this point, we'll go ahead and take a panelist format to the remaining discussion. So for each of these topics, Dana will provide a perspective from the acute rehabilitation setting, and then other panelists from Unite will provide information related to long-term care settings for each of the topics. So if you wanted to go ahead and start, Dana, would you? Mm-hmm.
Yeah.
In diversity and admission?
Say that again?
Oh, I'm sorry. I was thinking we were going on to the diversity and admission. But I'm sorry. Go ahead.
Yeah. So I wanted to mention that the tribes that we see, while we serve, we have a large population of the Navajo tribe. We also serve Havasupai. We have the Hopi, Guadalupe, White Mountain Apache, Yavapai Apache, and Yavapai Prescott communities, and we have relationships with each one of these tribes. For our admissions, our age range, our Native population, our average admission age is 62.2, the low being 22 and the high being 90. Of the admissions that we have, of our Native American individuals, 20% of them have suffered strokes. Some of these strokes are to our younger population that may have had a history of substance abuse. We do see that when you do have drug use, you can suffer from intracranial hemorrhages, unfortunately. Brain injuries, we have about 18% of our Native Americans have suffered a brain injury. These are generally male admissions. We have also major multiple trauma, which will include either brain injury or spinal cord, or maybe a combination of both. Our major multiple traumas generally tend to be horseback injuries. That is a leading admission for why people have traumatic brain injuries. Another reason is substance abuse. We do see a lot of our middle-aged men with alcohol abuse, and they're involved in motor vehicle accidents. We also have, because of the medical conditions, the chronic medical conditions, we see about 7% of our Native Americans coming in with some sort of amputation. length of stay, the course of care for our admissions, we do evaluation by discipline. We then layer in team conferences. We have individual family conferences, and then we daily round. So we have quite a few ways of looking at a patient, not only on a daily basis, but from a team perspective, and then from an individual family evaluation to really look at the cultural background of the families and how we're going to move them from illness to wellness and how we're going to get them back into the community. And one of the most difficult things that we face are trying to get people back into their very rural conditions, given the limitations of where they live. Our average length of stay in our building, it's shocking because if somebody's come in with a major stroke and they are hemiparetic, meaning they can't use a complete side of their body, our average length of stay for somebody in that condition is only 21 days. And we are only trying to get them to the lowest level so that they can return home and continue with their rehabilitation. And oftentimes some of these patients will need to move into that skilled environment for longer recovery because of the limitations on the reservation. Brain injuries generally stay between 10 and 31 days. Major multiple traumas can stay between 14 and 31 days. And amputations generally stay between 12 and 16 days. So you can see that these lengths of stay are very aggressive and still leave the individual with limitations. And I can pass that on to long-term care now.
Susan, do you want to go ahead?
On long-term care, hi, Susan Poyer from the Pine Ridge Indian Reservation. We have our tribal membership is 50,000 and over. We were fortunate to have our own nursing home because of the Affordable Care Act, which stipulates that Native Americans may have 100% reimbursement with Medicaid, which was a great thing for our tribe because our tribe is one of the poorest tribes in the nation. Right now, I believe we have 40 residents and we have 60 beds. We've been open for 3 years. Long-term care, we do not provide physical therapy, but we do have restorative. I have seen our residents are ranging between 40 years and up, and there's a car accident and whatnot. So they're coming in from car accidents, diabetes. We're 100% reimbursed, so we do have our staff ratio to residents is 3 staff to 1 resident because of our funding. Without the reimbursement, the enhanced reimbursement from the Affordable Care Act that they provided Native Americans, it would be impossible for our tribe to run such a facility as ours. Long-term care, I have seen our facility has a multi-purpose room, a movie theater. I mean, it is top of the state-of-the-art. So our younger generation residents that are in there, they prefer to stay there than leave, which is fine. But that is our facility, our long-term care. So, but just like skilled nursing, we do not provide physical therapy. We have restorative. We cannot provide IVs. We are long-term care. So long-term care means exactly what it means, long-term care. We cannot take traumatic brain injuries, spinal cord injuries. Skilled nursing and long-term care are different. And Tammy, I think you can touch base on that also.
Okay. And that is the difference in our facilities because we are considered a skilled nursing facility, so we can and are required to provide the speech therapy and the physical therapy and occupational as well as we do IVs and that kind of thing. But I think Joseph has some comments he'd like to add as well.
Adding that we have such a diverse levels of care at Laguna Rainbow Center in Laguna, New Mexico. We also have restorative services for our residents. But as far as PT and OT physical and occupational therapies. We don't provide that. We are a Medicaid facility. All our admissions in the last few months have had to apply for state Medicaid here in New Mexico, and unfortunately, we do not receive 100% reimbursement from the state. That's one project that our pueblo, our tribe, needs to work on with the state. So hopefully, with the turnover in leadership here in the governor's level in New Mexico, we'll be able to negotiate that full 100% reimbursement federal matching rate. But as was already stated, we've seen the trend of admissions in our nursing home of individuals at the younger age range of under 50 due to traumatic brain injury caused by car accidents, usually people abusing substances and having auto accidents. That's my background, unfortunately. I was abusing alcohol, drinking, and driving, and I crashed and acquired a spinal cord injury, but fortunately I'm able to provide my own care, and just listening to the differences about the length of stay at the acute rehabilitation setting, I was so fortunate that I was, well, not fortunate that I was hurt, but I was hurt 30 years ago, and I was able to stay in my rehab facility for almost 90 days at that time. I was Medicaid qualified, and I was able to, thankfully, with my spinal cord injury, I was qualified to stay that long. But again, many individuals on that side aren't able to. But going back to long-term care, we place individuals in our facility from the local hospitals, the rehabilitation hospitals, local. We have an Indian Health Service small hospital here in our area, and we sometimes receive referrals from that setting. Also, community referrals for our aged population, our older residents from the community, as they do have to be referred by their local doctor, but it's usually because of aging conditions, family not able to provide that level of care to their loved ones. So that does make up some of our residents. Thank you.
Thank you, Joseph. I believe now we'll move into funding sources.
So
Dana?
in order to come into the acute rehabilitation center, you have to have a funding source. And when we specifically look at our Native Americans that we treat, it depends on the age of the individual that's going to come into our facility. If we have an older adult over 65, we look to see that they do have Medicare. They've paid into the Medicare benefit so that they do have that. But I would say that the majority of our admissions are in the access area. In 2016, there were some changes to, like was mentioned, as the Affordable Care Act, which made it more accessible for our Native Americans to get the access coverage. They have changed in the Navajo Nation. They have done a nice job within the service centers to encourage each of the tribal members to go through the access application before they ask for funds from the tribe. The tribe is not necessarily a funding source. So that we see the majority of our younger natives being eligible for the access plan, and then we'll come into our facility once we gain approval from the insurance, in which we do not have any barriers for getting approval for. Some of our natives have employment, and so they can tap into their commercial benefits. I can say that that's probably the least access benefit. Unfortunately, not a lot of the natives that we treat have commercial insurance. We do see some that will be over income for reasons that I can't describe here, and they do not meet the eligibility for access. They are not employed, so they don't have access to commercial insurance, and so the service center will ask for tribal funding for those individuals. I have not, in all the years I've been doing this, have ever run across a tribal member that has ever been turned down for medical care for funding. Some of the difficulties with that, though, are post-acute service providers. IHS reimbursement is very slow and depends on how the funds are within the tribe. The majority of our admissions used to be just straight up IHS before the access changes, and you have to wait. We have never not been reimbursed, but you have to be a patient provider in order to get those funds. The other thing that we do see are natives that have come off of the reservation and live in urban areas, and so they're no longer living on the reservation with their families, and they have a major accident and they have no funding. I have seen individuals petition the tribe for special circumstances, and I have never seen them be turned away. The last one that I think could be a source of contention with the tribes is our veterans, our Native Americans that have served in a military capacity. And because of the lack of VA coordination on the reservation, at least on the Navajo reservation, they tend to go to their clinics versus coming out to where these veteran administrative facilities are. I most recently worked with a very young man who was involved in a motor vehicle accident. He wound up fracturing multiple body parts and was unable to bear any weight throughout his body. He had come off the reservation. He had suffered from PTSD and actually chose to get services in the Prescott area. And the Veterans Administration in our community of Prescott are very good to our veterans and found him. He came out of a substance abuse situation and found treatment through the Veterans Administration and then wound up having housing. So, however, he unfortunately was involved in this motor vehicle accident. He was able to return back to the Prescott community, and his family relocated with him to tap into those benefits. So it's something that needs to probably be looked at in the future.
Susan?
Okay, so I am also a licensed nursing home administrator, and I worked for the Oglala-Sioux Lakota Nursing Home, my home nursing home, for 3 years until I accepted another position. So in the Affordable Care Act, there's a clause in there that Native American tribes can get an enhanced rate where you get 100% reimbursement back to run your nursing home, which works out terrific for us. Our nursing home is in Nebraska, although our tribe is in South Dakota. We still have 160 acres in Nebraska, which was a blessing for us. At that time, South Dakota said they were not going to build any more nursing homes. So that was going to defeat the whole process of our tribe getting our own nursing home. But thankfully, the 160 acres in Nebraska, because we're right on the border, is in Nebraska. And because Native American Health Management in Lincoln stepped up and assisted us with all the funding, the startup cost, the financing, they found the lenders for us to build our nursing home, which in fact, because we get 100% enhanced rate, reimbursable rate, we can bill and yet still take the money which we make on top of after we pay our salaries and our medicine and the food and everything it takes to run a nursing home and pay off our loan that we had to acquire to build our nursing home. So there's a clause in the Affordable Care Act, which I'm thankful for Obama because he made it where Native American tribes have the opportunity to get 100% enhanced rate back for only long-term care, not skilled nursing. there is a difference. And also, the residents have to be on Medicaid. That's who we bill. We bill CMS Medicaid, and we get reimbursement back. And I always advocate if you need any help with startup, the building, financing, etc., call our company. We have experts who've been doing this forever and ever. So that has given us just financial independence. We do not ask our tribe for a penny. We don't go through our tribe, and our tribe is a private entity. We do have to, to get this whole process started, you have to 638 a contract through Indian Health Service. If you're just going under Indian Health Service, they're just the umbrella. It's just some bureaucracy, and it doesn't take very long at all to do. So if anybody knows of any tribes that need help in financing, startup calls, consulting, anything, Native American Health Management does that. So they manage our nursing home. They manage the Rosebud Sioux tribe. They're consulting with the Cheyenne River tribe. And we have other tribes that are interested in this. So I encourage anybody that needs help, to get their nursing home up and running. This is the route to go. So I always thank the Affordable Care Act because without that, we never would have a nursing home to this day. So for the long-term care, you have to be on Medicaid. Your state and your federal government have to work together to agree on this enhanced rate. And Nebraska, fortunately, worked with our tribe, and we're all very thankful for that. So South Dakota right now is working also with Native American Health Management. They're moving along very quickly, so we're thankful for that. So, and if anybody needs any assistance with that, please call Native American Health Management in Lincoln, and they can help you. Thank you.
Joseph?
At Laguna Rainbow Center, our residents are qualified for institutional Medicaid through New Mexico. Again, New Mexico is open to working with our local governments and entities. Our facility, we take in members of other Native American tribes. Our population, our census is approximately 8,000 Laguna tribal members, and so we do at times have make accommodations for non-Laguna, non-tribal members. So we've had residents at our nursing home from far away as Livingston, Texas. At one time, we had a resident from the Kickapoo tribe, and then we've had other members from throughout the Southwest United States. We serve other here in New Mexico. We have the 19 pueblos, and we also serve other pueblo nations, as well as mentioned the large Dene Navajo Nation. We have residents from that make up our population at our center, and it leads to quite interesting cultural issues at times because of the just the nature of our residents' upbringing. Pueblo and Navajo custom and tradition are not similar, and so if a resident isn't aware of who their neighbor might be, there might be a little bit of clash at times. But again, we work through those situations. The funding sources, again, we're totally Medicaid dependent. Thank you.
Can I add to that? This is Susan. Our nursing home also takes other enrolled members from any federally recognized tribe. So we do also have other native tribes that are in our nursing home. But with that saying, we have a lot of tribal members who have married outside. We have some Dene, CNAs, etc. So, which helps because if we have a Dene resident, then we also have a DNA CNA who understands the culture and also teaches the other nursing home staff the differences. I just wanted to put that out there. Thanks.
Susan, you don't have any Pueblo members at your nursing center?
Not yet.
Because we like to tease each other and say that, oh, there's a Laguna. Lagunas go everywhere, and then also with Navajos, also we tease each other. And man, there's a Navajo wherever you turn around, everywhere. So it leads to interesting dynamics at times or relationship building. So thank you.
And also the foods are so different. You know, I mean, we don't have sheep for the Dene, so but yeah.
Okay, moving on to challenges in transitions of care. Dana?
Yep, it's interesting to hear the differences within the tribes. We have, of course, the largest Native American area with the Navajo, and the Hopi sit right in the center of the Navajo Nation. And we serve both Navajo and Hopi as the majority of our admissions, and so you don't want to get that mixed up. Because it will be pointed out very quickly. So individuals and residents that live out in the Navajo Nation, Hopi Nation, there's a real lack of post-acute care in that large land mass that covers into New Mexico and up into Utah. There's one home health care that will serve that entire region. They won't serve everything. There's one nursing home. There's a few hospitals. There's the service centers. Therapy is provided at the service area. So we really do lack the ability to have a continuum of care within their own home community. Another issue is when, because there is not an acute rehabilitation hospital located on the land, they have to come into our more urban areas. And the practitioners in which they are now hospitalized in practice Western medicine. So if you are traditional, there is that barrier of trust. So we do work on trying to hire correctly and making sure that we have the culturally sensitive staff so that we can try to break down those trust issues. Bringing family in, the clans are big, and either they are a broken family or they're a family that's intact, but there's a large amount of them. And their ability to travel in the winter, in the mud season, trying to get off of the dirt roads, trying to come in, they get stuck. So access is really difficult. Also, communication is very difficult because there is lacking cell towers for their telephones to work. So if they have a cell phone, it may be text only, or it may not work where they live. So even trying to give updates when they can't come in. There is very limited, I think, just as you have mentioned, limited specialty treatment for long-term spinal cord and brain injury. This is something that we find to be very disheartening when we are attempting to get somebody back into their community. There is nowhere to send them, so we wind up sending them. In Arizona, Phoenix is the 5th largest metropolitan city in the United States, and that area services the majority of Hispanic people. So while there are tribes in the southern area, there is 28, I believe, tribes within the state of Arizona. That really is watered down in the numbers. So you have to transition them into a community where the families lose connection. And now there is no cultural sensitivity because you're just trying to find a facility that will take somebody for these longer term treatments. Fragmented family support comes in the frustrations of families trying to do the right thing for substance abuse members. Families become broken because of that. Families break apart and go through divorces because there's substance abuse within the family. And one of the things that we face too is just the pure lack of access to water, electricity, and plumbing. And I have not seen that over the many, many years that I have been doing that. It's still a very basic question that you ask individuals when they have suffered a traumatic event and their plans are to go back into their community. That is a basic question that we ask. And then because of substance abuse, again, they may have been couch surfing. They may have been going from home to home. They may be homeless and sleeping on the street. So again, we bring them in regardless of the social structure, and we do our best to try to place them back into a community that they can be sensitive to their needs. So those are some of the things that we find to be a challenge because of short length of stay and ongoing needs in the efforts of returning people back to the community in which they prefer to go to.
Susan?
But not over.
And I agree with you, Dana, because the same happens here in South Dakota. We are so far out ourselves that we have a lot of residents that cannot come home. They're over in Yankton, which is about 6 hours away, in a skilled nursing facility. So that's one of our barriers. We can't bring them home, and family gets upset. When people say a nursing home, they just assume, anybody can come home, and there's a difference between the skilled nursing home and the long-term care nursing home. And the reason we're not skilled is because of the financing. There's absolutely no way that the Oglala Sioux tribe can finance a skilled nursing facility. So, and also, I have a son that is disabled, and we had the flood hit us, and I'm on a dirt road. I live out in the country. So the police had to come and get him. He was sick, and the cop cars were all stuck across the creek. So they had to walk across our creek and grab him and put him on, they carried him. And so those are just some of the barriers that we go through, and it just happens to me, and I'm only 10 miles out of town, but we live out in the country, and we're on the dirt road. So, and I have my neighbors that live up on the hill. They have no water, so they bring the kids down to my home to shower. So it's really hard to put that in a picture to people that have never lived the way we live. But those are so many barriers that our people go through. And just like you said, the word you send the spinal cord injury people and we have to send them out to Yankton, which is 6 hours away from home. And that's a whole cultural shock to them. So yes, those are barriers, and that's where do we go from here? I have no idea. Thank you.
Joseph?
Just adding on, again, because of the types of disabilities that are acquired and lead to the placement in the acute rehab setting. And as Dana stated, no post-discharge, no places for these individuals to go to. I know of people who, again, have to leave their home and go to the urban setting to receive services. And then there's others who, like myself, who tough it out and just deal with the mud. And it leads to wasted time having to clean my wheels because I use a wheelchair all the time. But again, that's just what I deal with. But for other individuals who don't have that ability, they have to leave home. Or again, the other option is nursing home placement, where they are able to live a higher quality of life. But again, just listening to Susan's testimony, and then also my knowledge through meeting individuals throughout Indian country and some of the other roles I play, it's a desperate time out there, and so much work. We in Indian country we need more of our youth and tribal members to become medical professionals, to pursue their degrees, to become those providers. And only until then will our people be able to remain close to home. So again, it's just it's a trauma on our people and a loss of status. So we through our Unite group we hope to address those issues. Thank you.
Moving into ensuring cultural competency, Dana?
So just to probably just summarize this area, we're making an effort to consolidate hiring practices, providing traditional training, bringing in medicine men, adapting with food choices, having interpretive services available and not through the telephone because that becomes very difficult, but hiring staff that speak the Hopi language, that will speak the Navajo language, so that when you are practicing, there is somebody to connect to when you are in a situation where you are surrounded by people that are not of your background. Trying to bring in healers and working through the Western medicine and the Native American medicine with those healers and coming together to provide ceremonies that are sensitive to both the needs of a new MS patient, but still want to go to a hot house. So how we integrate and learn those things.
Aina?
So on the cultural competency here, that I know we try to make sure that we're aware of their cultural beliefs and values and finding this information out from them. Maybe during the admissions, are there one-on-ones, or even our plan meetings that they do have, but making sure that, what their requests are, they're readily available and offering to accommodate their traditional spiritual needs when requested, and being mindful that some of the younger residents may not be as traditional, but having that conversation to gain that understanding why. And now, they have the Language Act, technology, things like that out there that we're able to help incorporate in their care, in their needs, as requested. Traditional acceptance, having that resourceful relationship with community healers, inviting them in to smudge and theater when there's sweat going, being held, or even the hand drum songs, having them come in and participate in events in the home. Communicating in a manner that is culturally appropriate, language and attitude. Tone and approach go a long way with this, but then, for the ones that still, hold on to their language, making sure that, they have someone to communicate with. For those that aren't able to speak either, making sure, they get enjoyment out of just maybe hearing some songs, Sundance songs, but again, meeting their needs. Community involvement, engagement, getting them out there in the community, enjoying the powwow, ceremonies, dance and sweat, just making sure that we're meeting all those needs for them. And then understanding that all tribes have different ceremonies and beliefs. Again, just being readily available, but being here, we're very fortunate to have those close relationships, so we're able to call on requests when it's requested. Thank you.
Joseph?
For our center, we it's not a requirement, but again, since we're close to the Navajo Nation, the Acoma Pueblo, and then located here at Laguna Pueblo. A majority of our staff members are tribal people from the local area, usually a younger person. Our administrative staff, our nursing staff at time, they have to travel in. We don't have any staff housing here at our facility, so again, having different, well, there's a good mix, actually, I should say. Our department managers do mix with the nursing staff. We do have some native nurses, so they're able to convey some of the aspects of what culture and what it means to our native people. Our administrator currently is a non-native person, and again, it takes a lot of dialogue, and because again, when a person is a non-native, new to our community, learning our ways, it's not an overnight thing. So again, we have to ensure that our administrator and any other non-native person are aware of those needs, of cultural aspects of the treatment and the way they can give care, provide care to these residents has to be respected. And so again, it's the duty of our board of directors to come up with policies and procedures that reflect that culture, our culture, and also to have employee handbooks and guides that reflect that culture. So again, trying to ensure that our residents are properly, their well-being and peace of mind is maintained, respecting their cultural dynamics. Thank you.
And moving on to staff training, Dana?
So, Joseph, I'd like to hear what you said about your administrator. And because our facility is in a urban setting, our administrative staff are non-native for the most part. But we have embraced our community in such a way that our administrative staff, when our building was built in Flagstaff, before the building was even, the land was cut, we had a healer come and bless the land. We also shifted and worked against our company to shift our building entrance to the east, and then made sure that each one of our rooms had east-south. You knew the direction of the room, so that when somebody wanted to pray, they knew which way they were sitting within each of the rooms that somebody would be in. So we've taken some very careful, sensitive steps to try to break down some of those barriers when you are not native and providing care to somebody that is from the native community. So I appreciate that. We do sensitive hiring, and we do work very closely with our service centers. We have them in to our facilities and organize events so that we can learn from healers, from healthcare people that are more versed in the traditions of the Native American care.
Ina?
For staff training here, I feel like an orientation process for all employees is very important. Becoming well known to others. I feel like it improves the quality of care being given by emphasizing these care partners' empowerment, so giving them that education, that training, as well as adopting like a team-based approach that works. So making sure that included in that is the elders, the families, and the employees. So everyone is always on that same page of where that quality of care, that communication, all that's rounded very well for them. The continuous education training weekly to help support the personal and team development throughout the organization. Making sure that, we're strengthening their strengths. We're looking at that, working on that, and helping them. Because all this is just going to do is just making it that quality of care be even better for our elders' care. Ensuring that resources are accessible for all care partners, and again, that's including the elders, the families, and the employees, taken in their care plans, even events, families coming in, community coming in, making sure all is involved for the elders. And in the hiring, growth, and evaluation, nurturing those relationships with others, how to recognize and grow their needs. And in there, we value that person-directed care here. So with all that, with the staff training, it does pay off hugely. It's just making sure it's repetitive, it's routine, making sure that we are communicating openly and providing timely feedback with the education to ensure that the elder care is being provided in accordance with, we deal with policies, the procedures, rules, regulations. So making sure that's all met also in that. Thank you.
Thank you, Ina. Moving into changing needs, Dana?
So, as we know, lengths of stay are getting shorter and shorter. Younger natives are staying in urban communities, away from their homes and have been displaced for medical reasons. Families are being displaced because of complex medical care. They're being taken down into the Phoenix metropolitan area and are not able to stay close to their home. And then limits in cultural sensitive post-acute communities for young natives when they do get displaced into these larger urban areas. There is not the cultural sensitivity for them. We just need more. We need more in regards to independent assisted living, skilled nursing facilities that are capable to take care of these higher acuity patients so that they can maintain those cultural roots and stay close to their home.
Thank you, Dana. I think that was the idea in mind when the Eastern Shoshone tribe built Morning Star, and it is a skilled nursing facility so that people could stay in the community because we're very rural here too, and so community members are able to still be around their relatives, their families, and we do take them out in the community all the time so that they can still be a part of it. But what we are seeing is younger populations coming as well, and as we've mentioned previously, several of us have mentioned, whether it is car wrecks, brain trauma, chronic diseases, things stemming from alcohol abuse or drug abuse, we are seeing these younger populations, and so we do have to do things different for them, whether it's diets, their activities. Obviously a 35-year-old doesn't want to do the same thing that a 90-year-old, for example, might enjoy in activities, and so we're having to be creative in trying to meet the needs of everybody here. We also have people that have been referred to us, but they want to stay in their home, and so they're trying to make home health work, which only stops in to see them one time a day, and so we're having some problems with that because they really are needing 24-hour-a-day care. We also have seen a huge change here at our nursing home because it is an older nursing home and was designed a long time ago, so it has co-occupancy of the Medicaid law requires 2 people per room. People nowadays are wanting to have a private room, and so that is causing some issues for us as well. And I know a few nursing homes close by us are redesigning their facilities to include more private rooms, and I think that's going to be a trend in the future we see of places trying to allow people to have that privacy. Joseph?
We're facing those issues, an aging nursing home, and so again, and then with the aging nursing home, requests for private rooms because of the demographics or the makeup of our population. Younger individuals, again, wanting private rooms. We really have a need for a new facility because of internet technology, because of health technology playing such a part, and being able internet-based health technology, health services being a way to be able to receive better medical care throughout our community. We have those needs in our facility. That would just improve the quality of life all around, not only on all levels, just the basic quality of life for our residents, again, because of those changing needs. We have to stay ahead of the curve as best we can, but because we're tribal communities, we have been lacking behind. And so, but this is, I feel, because we are, as far as long-term services and supports go, Unite is attempting to organize the information, as Susan earlier alluded to, building nursing homes or building settings for our residents to live high quality of life close to home. That's so key, but that takes, again, many levels of work, funding sources and advocacy in Washington and in our state capitals. So, again, we have to do that work. Family dynamics, until people are able to get jobs closer to home, then they are still going to be turning to whatever source of housing for their loved ones that they have access to. So we're going to be playing a key role in that care of our tribal members. Thank you.
And I guess, Julie, it's back to you.
Great. Thank you so much, Tammy, and thank you to all of our panelists. If you have any questions for any of those that were providing information to you today, here's a list of all of their emails, addresses, and their names. Please feel free to reach out to them directly if you have any questions about any of the topics that they addressed. At this time, we're going to go ahead and transition into a brief question and comment session. So if you as an audience member have questions for any of our panelists, please feel free to enter those into the Q&A pod, and we'll spend just a few moments addressing those questions. I do know that we have gone over time, so we thank you for staying with us to hear all about the information that our panelists had to share today. So one question that did come in during the presentation, Dan, I'm hoping you can address this, but does your facility accept patients out of the state? From out of state.
Yeah. Yes, we do. We coordinate throughout the United States.
Okay, great.
And there's another question there regarding IHS.
Yes, another question that came is, do any of you participate or do any of the patients have Indian Health Service, or are most of the patients enrolled with Indian Health Service?
I think that's an excellent question, and we have a lot that are enrolled, that are eligible for IHS benefits, and it's just right across the road from us. So they are our provider for medications and our doctor provider. However, IHS does not pay a portion of their nursing home care.
And I'll answer that for the Pine Ridge tribe. Because we're in Nebraska, our providers are in Nebraska. Our clinics, we take our residents to all the clinics and the providers in Nebraska. And unfortunately, our residents prefer it that way. And we're only 3 miles from our big hospital, our IHS hospital clinic, and we do not utilize them at all. Unless we have an emergency and we need someone there, IHS will come in the ambulance and will take them. That is the only time we will utilize them.
This is Joseph. We have a local IHS facility, but unfortunately they do not have very much services. We use them for emergency, and for some primary care, but most of the time our residents, if they need special services, we have to transport them to Albuquerque, New Mexico, which is in about an hour approximately away from our facility. So again, it places a burden on our facility, but mostly on our residents because of the stress that it places on them transporting.
Okay, again, if you have any questions for any of our panelists, please enter those into the Q&A pod. Okay, and as I see that there are no questions rolling in, and to be mindful of everyone's time, we'll go ahead and move into wrapping up for today. So I'd like to thank our panelists for joining us today and sharing information about post-acute care. In closing, I'd like to remind everyone that today's webinar was recorded and that the audio and presentation slides will be made available online at cms.gov on the Tribal LTSS Technical Assistance Center website. Thank you again for joining today's webinar. Our session is now concluded. Thank you so much.